Okay, let's unpack this. Welcome to the deep dive. Today, we're taking a deep dive into a topic that really touches so many lives. Women's health. We've sifted through clinical guides, key research, basically distilling some pretty complex medical info into something clear, actionable for you.
Yeah, and our mission here isn't, to turn you into a doctor overnight. That's not the goal. It's really about becoming incredibly well informed. And what's truly fascinating is just how interconnected these seemingly separate aspects of health actually are.
Right.
Like you'll see how talking about contraception might suddenly link up to crucial details about cardiovascular health. It's quite interesting. Our goal is to pull out the most important nuggets of knowledge so you can have, more informed chats with your healthcare providers, or maybe just satisfy that curiosity about your own body.
Exactly. And we're going to cover quite a bit of ground pretty efficiently, actually, giving you those aha moments without that feeling of information overload. We're talking contraception options, critical screening guidelines for cervical and breast health, and then demystifying conditions like menopause, endometriosis, PCOS. You'll start to see the bigger picture, hopefully. So let's start with something many people navigate: contraception. The core idea, obviously, is preventing pregnancy. And thankfully, there are, well, a lot of methods out there. We'll look at non-hormonal, progestin-only, and combined hormonal types.
Okay, so to give you the rundown on the specifics, for non-hormonal, the main one is the copper IUD, often known as Paragard. Then you got the progestin-only options. This includes things like the mini pill, the Depo-Provera shot, various progestin IUDs, and the implant, Nexplanon. And these are often a good fit for people who are breastfeeding, for instance.
Okay.
And then the combined hormonal methods. These have both estrogen and progestin. So the familiar birth control pills, Patrazulane or Orthovra, and the vaginal ring, like Nuvaring.
Now, here's something really crucial and maybe a bit overlooked sometimes. Not all these methods are right for everyone, especially those combined hormonal ones. Our sources really hammer home the critical contraindications.
Absolutely. And one of the most important warnings, something our sources flag as a teacher's tip, is about migraines with aura. That's a strict no-go for combined hormonal methods.
Why is that? Exactly.
Well, it's because the estrogen you get from these methods, the exogenous estrogen, it can increase certain things called coagulation factors in your blood. Basically, it makes your blood a bit more prone to clotting, and that significantly raises the risk of stroke.
Wow. Okay. That's serious.
It is. And beyond migraines with aura, there are other big ones.
Yeah.
A history of blood clots like VTE, any estrogen-dependent tumors, severe liver disease, and smoking if you're over 35. Those are all general contraindications for combined methods.
And within those combined methods, are there specific ones that carry, like, even higher risks?
Yes, there are distinctions. The contraceptive patch, for example, it actually carries the highest risk of blood clots among all the combined methods.
Really? Why?
It seems to be because of its higher, more consistent estrogen concentration compared to some pills or the ring. It's just quite potent. And then there's Depo-Provera, the injection. That one's been linked to decreased bone mineral density over time.
Oh, right. I've heard about that.
So if you're using Depot, calcium and vitamin D supplements are really essential. And typically its use is limited, maybe 2 to 5 years generally.
Okay, let's tackle a super common practical question. What happens if you just forget to take a birth control pill? It happens.
It does. And there's a clear protocol. If you miss just one active pill, the advice is take it as soon as you remember, even if it means taking 2 pills in one day.
Okay, take 2 if needed.
Right. But if you miss 2 active pills, the guidance changes slightly. You should take only the most recent missed pill, discard the other missed ones, and this is crucial, use a backup method, like condoms, for the next 7 days.
Got it. 7 days backup for 2 missed pills.
Exactly.
So I guess the big picture takeaway here for contraception is, yeah, you have lots of options, but you really need to understand the specific risks and contraindications based on your own health. It's a conversation you absolutely have to have with your provider.
Couldn't agree more.
All right, moving on from reproductive choices, let's pivot to another really vital area of proactive health: cervical health and preventing cervical cancer.
Okay. The fundamental thing to grasp here, the absolute basic, is that human papillomavirus, HPV, is the primary cause, especially types 16 and 18. Understanding that link is just foundational for prevention.
And prevention. That immediately makes me think of the HPV vaccine. What's the latest there?
Right, the Gardasil vaccine, it's highly recommended, usually given around age 11, but it can start as early as 9. And there's catch-up vaccination recommended up to age 26 if you missed it earlier.
Any side effects to be aware of?
The main one noted is syncope, which is fainting. It doesn't happen often, but because of that risk, they advise patients to just hang around, be observed for about 15 minutes after getting the shot.
Good to know. Okay, let's get into the screening guidelines for cervical cancer. They can seem a bit confusing sometimes with different groups, maybe saying slightly different things.
They can seem that way, but our sources lay it out pretty clearly. Basically, you've got the pap smear, which looks at cells that cytology, and HPV testing, which looks for the virus itself. Sometimes they do both together, called co-testing.
So how does it work? When do you start?
Generally, screening starts at age 21. At that point, it's usually a pap smear every 3 years. Then once you hit 30, the options kind of open up. You can stick with the pap every 3 years, or you could switch to primary HPV testing every 5 years, or do the co-testing, pap plus HPV, every 5 years.
Okay, so more options after 30.
Exactly. Though, it's worth noting, the American Cancer Society actually prefers starting a bit earlier, at age 25, and going straight to that primary HPV testing every 5 years. And you can typically stop screening around age 65 if your previous results have all been negative, or also after a total hysterectomy, but only if the hysterectomy was for a benign reason, not cancer-related.
What about those results that aren't quite clear? You hear about ASIUS, sometimes atypical squamous cells of undetermined significance. What happens then?
Right, ASCS means they see some abnormal cells, but it's, well, undetermined if they're serious or just minor changes. For patients 25 and older, the standard next step is what's called reflex HPV testing. They usually use the same sample to check for high-risk HPV types. If you're younger than 25, though, the recommendation is usually just to repeat the pap smear in 1 year.
And why is that HPV test so important there?
It goes back to the virus. When high-risk HPV causes problems, it actually integrates its own DNA into the cervical cell's DNA. This messes with the cell's natural tumor suppressor genes, basically taking the brakes off cell growth. That uncontrolled growth is what screening aims to catch really early.
So what you should really remember from all this is these guidelines. They're designed to catch changes super early, often way before any symptoms show up. It just highlights the power of routine screening.
Absolutely. Early detection is key.
Okay, let's shift gears again. Moving to another vital area, breast health. We'll touch on screening, some common benign things, and importantly, those red flags that need immediate attention.
All right. Breast cancer screening. The guidelines here have seen some updates recently, moving towards more consensus. The USPSTF, the U.S. Preventive Services Task Force, their newer guidelines recommend screening mammograms for all women starting at age 40, every 2 years. ACOG, the American College of Obstetricians and Gynecologists, suggests starting at 40 and doing it every 1 to 2 years. And the American Cancer Society says routine annual screening from age 45, but with the option to start at 40 if you choose.
So generally starting around 40 seems to be the trend now.
Yes, the consensus is definitely shifting towards starting earlier for average-risk women.
What about breast self-exams? They used to be emphasized so much.
That's true, but our sources state they aren't routinely recommended for screening anymore, mainly because studies didn't show they significantly reduced deaths from breast cancer. However, and this is important, breast awareness is absolutely key.
Breast awareness, what does that mean exactly?
It means knowing what's normal for your breasts, how they usually look and feel, so that you can recognize any changes, a new lump, skin changes, nipple discharge, anything different, and report it promptly to your healthcare provider. That personal knowledge is invaluable.
Makes sense. Let's talk about the most common type of breast cancer itself. What should people know?
Okay, that would be invasive ductal carcinoma, or IDC. It accounts for the vast majority, like 80% of invasive breast cancers. It starts in the milk ducts, as the name suggests. Often, early on, it's asymptomatic, found only on a mammogram. But later signs to be aware of include a lump that feels hard, painless, and doesn't move easily. Also, skin dimpling, sometimes described as looking like an orange peel, that peau d'orange appearance. Nipple retraction, discharge, or just changes in the breast's size or shape.
But thankfully, finding a lump doesn't automatically mean cancer, right? Could you talk about fibrocystic breast changes? That's pretty common.
Oh, absolutely. That's a really crucial distinction. Fibrocystic changes are, in fact, the most common cause of benign breast lumps. It's characterized more by a general lumpiness, maybe some tenderness or pain, and often these symptoms fluctuate with the menstrual cycle. It's frequently felt in the upper outer parts of the breast. Management is usually about reassurance, confirming it's not cancer, maybe suggesting supportive bras, using over-the-counter pain relief if needed, and sometimes lifestyle tweaks like cutting back on caffeine or fat.
Okay, that's reassuring. What about something less common, but kind of intriguing? Galactorrhea.
Ah, yes. Galactorrhea, that's basically breast milk production in someone who isn't breastfeeding. And interestingly, it can happen in both women and occasionally men.
Really? Men too?
Yes, it's usually benign, but the causes are quite varied. A common one is hyperprolactinemia, meaning high levels of the hormone prolactin, often from a tiny benign growth on the pituitary gland called a prolactinoma. Other causes can include hypothyroidism, certain medications like some antipsychotics or antidepressants, and even sometimes just frequent breast stimulation. The first step in checking it out is usually a blood test for serum prolactin levels.
Right.
Then maybe thyroid tests or even a pituitary MRI depending on the results.
Fascinating. So
Yep.
the big picture takeaway here, it seems, is pretty straightforward. While most breast lumps are benign,
Right.
any new or concerning change needs a full workup. No exceptions. Even if you feel a lump and then have a mammogram that comes back negative, that still needs more investigation, like an ultrasound or maybe an MRI and seeing a specialist. You have to follow through.
Absolutely. Never ignore a change. Follow-up is critical.
Okay, let's transition now to menopause, a really significant life stage and one that's often maybe a bit misunderstood.
Yes, it's a major transition. Officially, menopause is defined pretty simply. It's the cessation of menstruation for 12 consecutive months. It marks the natural end of reproductive fertility. It's important to remember it's a physiological event, not an illness itself.
What often surprises people, I think, are the wide range of symptoms. And crucially, there's one very important red flag associated with this time that everyone needs to know.
Definitely. The common symptoms can really vary in intensity from person to person, but they often include those vasomotor symptoms. That's the medical term for your body's thermostat going haywire, leading to hot flashes and night sweats. There's also urogenital atrophy. This is thinning and drying of the vaginal and urinary tract tissues, which can cause discomfort like vaginal dryness or painful intercourse. And yes, psychological symptoms are common too. Mood swings, sleep problems, sometimes trouble concentrating.
And that red flag.
Yes. The critical clinical alert here is postmenopausal bleeding. Any bleeding after you've gone 12 months without a period is always considered abnormal. It's a major red flag specifically for endometrial cancer. It absolutely always requires an immediate referral for an endometrial biopsy to figure out the cause. No waiting.
That's incredibly important to emphasize. Always investigate postmenopausal bleeding. Okay, let's talk management options, especially hormone replacement therapy, HRT. It can be a complex
It
decision.
really can be. For women who are significantly bothered by vasomotor symptoms like hot flashes, HRT is certainly a very effective option. Now, here's a super important point. If you still have your uterus, you must take combination HRT. That means estrogen plus progesterone.
Why the combination?
It's crucial because taking estrogen alone, what we call unopposed estrogen, can cause the lining of the uterus, the endometrium, to thicken abnormally. That's endometrial hyperplasia, which significantly increases the risk of endometrial cancer. The progesterone prevents that. Estrogen-only HRT is strictly reserved for women who have had a hysterectomy.
Okay, that makes sense. But HRT isn't without risks, right?
Correct. It's vital to weigh the benefits against the potential risks. HRT does carry an increased risk of blood clots, stroke, and also breast cancer. There's also some evidence suggesting that cardiovascular risks might increase if HRT is started more than 10 years after menopause actually begins. So timing matters too.
Are there alternatives for women who can't or don't want to take HRT?
Yes, definitely. For vasomotor symptoms, some antidepressants like paroxetine, Paxil, have been shown to help. And for localized issues like vaginal dryness, topical estrogen preparations, creams, rings, tablets that are inserted vaginally can be very effective with minimal systemic absorption.
So the key takeaway for menopause seems to be it's a natural process, but understanding the symptoms, knowing that critical red flag of postmenopausal bleeding, and really discussing the nuanced risks and benefits of management like HRT with your doctor is vital for making informed choices during this big life change.
Exactly. Informed choice is key.
All right, to wrap up our deep dive, let's explore a few conditions that can impact women really throughout their reproductive years and sometimes beyond. We're talking painful periods, endometriosis, and PCOS.
Okay. Let's start with dysmenorrhea. That's just the medical term for painful periods. It's important to differentiate between primary dysmenorrhea, that's period pain, with no underlying pelvic disease, usually starting within a few years of getting your first period, and often managed well with NSAIDs like ibuprofen or hormonal contraceptives. And then there's secondary dysmenorrhea, where the pain is caused by an underlying condition like endometriosis, which we'll talk about, or maybe uterine fibroids.
Okay, so let's unpack endometriosis then. It sounds like a really complex and often painful condition.
It is. Endometriosis is a chronic inflammatory condition. Basically, Tissue that's similar to the uterine lining, the endometrium, starts growing outside the uterus. Common spots are the ovaries, fallopian tubes, the pelvic lining. And this misplaced tissue still responds to your monthly hormonal cycles. It can grow and bleed, causing inflammation, chronic pain, scarring, and adhesions.
What are the main symptoms someone might experience?
The classic symptoms include chronic pelvic pain, really severe period pain, painful intercourse that's dyspareunia, infertility can be a major issue, and sometimes heavy periods or even bowel or bladder symptoms that flare up during menstruation.
How is it diagnosed for sure?
The definitive diagnosis is made through laparoscopy. That's a minimally invasive surgery where they can directly visualize the implants and take biopsies to confirm it's endometrial tissue. Treatment then focuses on managing symptoms. Options include pain relief with NSAIDs, hormonal therapies to suppress the growth, like birth control pills, progestins, or stronger drugs called GnRH agonists, or sometimes surgery to remove the implants.
Okay. Now, here's one that seems incredibly common and has really wide-ranging effects. Polycystic ovary syndrome, or PCOS.
Yes, PCOS is a very common endocrine disorder. It's considered a lifelong condition. It's primarily characterized by having high levels of androgens, though those are often thought of as male hormones, though women have them too. These high levels can cause symptoms like hirsutism, which is excess hair growth in a male pattern, like on the face or chest, and often severe, persistent acne. Other key features usually include irregular or absent periods, and often, though not always required for diagnosis, the appearance of multiple small cysts on the ovaries on ultrasound, hence the polycystic name.
And it's not just about periods and acne, right? There are longer-term health implications.
Absolutely. That's a crucial part of understanding PCOS. There's an increased long-term risk for several serious issues. Infertility is common, insulin resistance, which can lead to type 2 diabetes, high cholesterol or hyperlipidemia, and even an increased risk for endometrial cancer and possibly ovarian cancer down the line.
So how is PCOS managed?
Management really focuses on two things: controlling the immediate symptoms and mitigating those long-term health risks. Metformin, a diabetes medication, is often used to help with insulin resistance. For regulating periods and managing the androgenic symptoms like acne and hirsutism, combined oral contraceptive pills are typically the first-line treatment. Lifestyle changes like diet and exercise are also really important.
Wow. So the overarching message from covering dysmenorrhea, endometriosis, and PCOS is just how intricate that interplay between hormones and overall health really is throughout a woman's life. It really underscores why, ongoing management and just being aware of your body is so crucial for long-term well-being.
Couldn't have said it better myself. That awareness is key.
Well, we have certainly covered a lot of ground in this deep dive, from, everyday choices like contraception all the way to these complex, often lifelong conditions like PCOS and endometriosis. Our goal really was to give you that shortcut to being well-informed, providing those maybe surprising facts and essential insights that help empower you.
Yeah, and this deep dive, it really raises an important question, doesn't it? As we've seen, women's health is incredibly dynamic. Guidelines change, our understanding evolves. The information we've talked about today is powerful, fundamentally, because it empowers you to be an active participant in your own health journey.
So what stands out to you after listening to all this? Maybe consider how, now that you're armed with this deeper understanding, you can engage more effectively with your own health, your own journey, and advocate for yourself with your providers.
And maybe a final thought to leave you with. Beyond just the specific facts and guidelines we've discussed, consider this. How does being truly proactive about understanding your body, paying attention to its signals, and seeking regular medical guidance transform how you manage your health? It shifts it from just reacting to problems to having this continuous, empowering conversation with your own body. Your body's always communicating. The real question is, are you truly listening to what it tells you?